Hello, welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture with Digital Pathology Association and Path Presenter. Our case today comes from the realm of GI pathology and is a somewhat unusual case, although I think we can all learn something just about every day if we're paying attention. The patient is a 75-year-old man who noted a change in his bowel recently and came to medical attention. He is the resident of an assisted living facility, and he noted that what appeared to be melanotic stools. Of note, he is quite some time post-cardiac transplantation, and is on a number of immunosuppressants. He has type 2 diabetes and secondary nearly end-stage renal disease. And so he's got a number of medical problems, as can be surmised. This sort of presentation, I think, highlights a number of questions that might be asked, of course, renal disease, GI disease, immunosuppression, and so forth. But let's look at some of the immune-related issues in bowel disorders. So we're all familiar with the many opportunistic infections, the common and the bizarre that can occur related to immunosuppression, ranging from cryptosporidia to other parasitic disorders, granulomatous disease, and a number of viral infections, of course, as well. In addition, though, some of the immunosuppressants can have direct drug toxicity effects in the bowel that can induce ischemic changes or ulcerations or other sorts of lesions. And in this patient, of course, we should be mindful of renal failure issues in terms of medications such as various polystyrenes and other binding agents that might be used. In addition, though, immune suppression by shifting the nature of the various T and B cell components that may be present in the body can give rise to both graft versus host disease or other inflammatory diseases, maybe recrudescence of inflammatory bowel disease or other sorts of things. And then we also have various so-called opportunistic neoplasms that can ensue, ranging from the lymphoproliferative diseases and so forth, Kaposi sarcoma, as well as a number of other epithelial-based lesions as well, which can become more prevalent with alteration of the immune status in a patient. And then finally, various vascular diseases, including veno-occlusive disease, have been associated with immune suppression. So this sort of steers our mind to a couple of possibilities as we consider this patient's pathology. Here we see what this patient's bowel biopsies looked like. You can see here a number of colonic biopsies. And on evaluation, the endoscopist said that the bowel appeared somewhat hyperemic. There was some oozing blood, but no focal lesions were identified. We've got several fragments of tissue, and from this low magnification, I think you can see that each one of them appears to be somewhat abnormal. We'll start off with this one over here on the far right and just take a look and see that we have some of what appear to be normal size glands remaining here with a little bit of mucin to them. And then a lot of very small, shrunken type of glands amidst a somewhat inflammatory pattern within the stroma. There is a rare lymphoid aggregate here, and you can see that the glands in general appear to come fairly close to the muscularis mucosa. Looking a little bit on higher magnification here, we can see that the glands have this loss of cytoplasm, some with some cystic dilatation, various degrees of reactive nuclear atypia kind of changes, some macronucleoli, and the lamina propria has a mixture of inflammatory cells, mostly plasma cells, and maybe a few stromal macrophages with pigment in them, not much in the way of eosinophils or neutrophils. Looking at the glands here, we don't see what we might be concerned about, a graft versus host disease. We don't see any evidence of apoptotic cells, a few type of regenerative mitoses in some of these cells, and interstitial areas of hemorrhage, as you can see here. And this sort of a change is present, as I said, in all of the tissue fragments that we have in this patient. Now, these more preserved normal glands have normal amounts of cytoplasm, but as you can see here, we do have in the crypts here a little trace of apoptotic change. So that's significant to note as well, that we've got a few little fragments of karyorectic debris, a little bit of debris in the gland lumina in a few foci. Looking again at some of the other areas, we'd be looking for possible viral inclusions and so forth, although this sort of a diffuse colitis would be quite unusual for an infectious viral-related colitis. But with some of these macronucleoli, you might wonder about CMV. And we did evaluate for that in this case, which was negative. Now, the other feature here, of course, is these withering gland type appearance, which in some respects could be suggestive of ischemic changes or so-called toxigenic type changes. We don't have any pseudomembrane formation, and it doesn't look as though we actually have frank hemorrhage off of the surface, although the surface epithelium is quite denuded in this situation. So in looking at this patient's history, we noted that the patient was on a number of medications, specifically to manage his renal disease, but also to suppress his immune function. And one of these was a medication called mycophenolate. And that's the drug that we want to discuss a little bit at this point. So mycophenolate mofetil is recognized as an entity with having GI complications. It's used most frequently in solid organ transplant patients, renal transplants, but also liver occasionally and cardiac transplants. And interestingly, it's used to treat or prevent graft versus host disease, but ironically can appear histologically very similar to that, as we saw those little foci in our case of Karyarexis and Karyarctic debris in the gland crypts. Now, most frequently it involves the colon rather than the upper GI tract, but at really any level can be involved. And while the symptoms most frequently are diarrhea, nausea, vomiting, occasionally we can see bleeding or other symptoms as well. And this actually has quite a broad spectrum of possibilities in terms of patients, because really up to 30% or more of patients who use this drug will manifest some sort of GI symptoms and changes. Now, histologically, it's quite interesting because it can have these graft versus host-like areas. We had a little bit of that. It can have inflammatory bowel disease type of changes with glandular architectural changes and mixed inflammation. It can also have some ischemic-like changes. So we saw some gland withering sorts of features that we have. And then a purely self-limited colitis type of picture can also be seen. I think in our case, we have a little bit of a combination of GVHD and inflammatory bowel disease and a little bit of ischemic type change. Now, the treatment of this, of course, is drug withdrawal or reduction in dose. And the patients, in fact, respond very well to that kind of treatment and will recover quite nicely in that. Of course, it's a balancing act with the other disorder that you're trying to be concerned about. So in summary, that's our case for today. Final diagnosis is mycophenolate-related pan-enteritis in a post-cardiac transplant patient. And if you enjoyed this, we hope that you'll give us a like. We welcome you to subscribe so you'll catch future releases on our channel. And of course, we always welcome your comments, feedback, suggestions for how to make the content more valuable and useful to you. So appreciate you joining me, and we'll look forward to seeing you in on a program soon. So until next time, thanks again for joining me.